Hello, everyone, and good afternoon. I'm Christina Haas, the Community Engagement Coordinator for the Community Outreach and Engagement Office of Wilmot Cancer Institute. And I would like to welcome you to today's webinar, Your Voice Matters, Using Patient-Reported Outcomes, or PROs, to Enhance Cancer Care. This webinar is part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CERTEC, and the Community Cancer Action Council, or CCAC. This live event has been approved for one AMA PRA Category 1 credit, one CNE credit for nurses, and one contact hour for social workers. If you would like to receive credit for attending, make sure to fill out the post survey. The link will be provided when this webinar closes, as well as in a follow-up email. Our presentation today will be followed by a facilitated Q&A session. So throughout this presentation, please feel free to answer any questions into the Q&A box located at the bottom of your screen. So since we have a large panel today, I will now hand it over to Dr. Michelle Janelsons, who will start our discussion.
Great. Thank you, Christina. Thank you for having us today. I am going to just share my screen. Okay. Do you see the presenter, the main slides?
It has the side slide as well.
Okay, so let me just...
Perfect,
Okay.
just the presenter slide.
Okay, so now you just see the presenter slide. Okay, great. So I just want to thank everybody for being here today, and we're looking forward to an engaging discussion with our esteemed panelists that are here with us. So I just want to first give a brief introduction to everyone that is here leading this seminar today. So I'm Michelle Janelsons. I am a professor here at University of Rochester and Wilmot Cancer Institute. I do a lot of research in patient report outcomes and specifically focus in cognitive health. I'm here with my partners, Dr. Julie Burkhoff, who's director of Wilmot Regional Nursing, Dr. Jason Zittel, who's an assistant professor in hematology oncology, Tara Coffey, who's a manager for community outreach services as part of Noise, and also Gail Feathers, who also works at Noise as a social worker. So we're really excited to have a really engaged discussion, and each of our experts are going to be talking about their roles and expertise as it relates to patient report outcomes and patient experience and work that they're leading. I'm going to first set the stage by talking about what patient report outcomes are, how it relates to symptom trajectories, and give some examples of some really seminal research studies that have really given us evidence that this is very important and can help with patient care. So just want to first give some background about our division. So I'm chief of Division of Supportive Care and Cancer, Department of Surgery. And as I mentioned, my work focuses on cognitive health. We really live by the motto of helping good people through lousy times when they undergo diagnosis and treatment of cancer. And our goal of our research in our group is to improve cancer-related side effects, toxicities, improve overall quality of care and quality of life. And so we focus on a number of different outcomes of different symptomatic toxicities. We also focus in the biology of trying to understand those interventions, and we do numerous different study designs, including qualitative and observational research to clinical trials. So I want to first talk about the fact that symptoms change and trajectories are fluid. So sometimes symptoms can be acute. These are problems that can develop early on as part of diagnosis and during treatment, and sometimes they can resolve. Sometimes problems can develop during treatment and they can become persistent, and sometimes symptoms can be more delayed, even as treatment is ending or post-treatment. And so, one tool that we can use to monitor symptoms is using patient report outcomes. And so, this is basically, or PROs, as I'll say, this is a really great tool, and where this really harnesses your voice as an individual who can tell providers about their health. And so they're direct reports from patients about their health symptoms and treatment effects using standardized questionnaires that have been validated in numerous research studies. They often, in the setting we're talking about today, focus on physical symptoms, treatment toxicities, or other psychosocial problems, and overall health related quality of life. The goal was to really capture whole person impact of cancer and treatment. And these are both used in research and in clinical practice to help influence care. So, some examples of some really important types of outcomes that are measured by different PROs in cancer care in the context of cancer treatment are those that are assessing symptomatic adverse events or symptomatic toxicities, impact of disease symptoms, looking at physical function, frailty, looking at cognitive function, and looking at emotional and social well being, and how those all impact overall health related quality of life. And this has become very important as part of clinical trial monitoring and major groups, including the National Cancer Institute, the FDA, Cancer and Aging Research Group, and other groups have really advocated for use of different PROs in cancer care. So, why are these important? Well, one is that they can help us understand direct details that clinical outcomes cannot. They can help us track progress longitudinally. They can enhance inpatient experience and engagement. And one of the ways that that can occur is by improving communication and clinical decision making if something pops up. They can ultimately help drive better health outcomes and in the management of symptoms, short and long term. And so just want to give one example from a study that was done that was led by Dr. Muhile's team looking at different symptomatic toxicities by patient report and by clinician rating. And this is something that really showed that patients were able to identify more severe toxicities than the clinician grading, and that these were more closely aligned with declines in physical abilities, and that their severity was associated with decline in physical function and overall activities of daily living. Now, the clinician rated toxicity information was still very important and helped understand things related to independence, impact on overall daily functioning. So they're both really important. But that symptomatic toxicity from the patient reporting allowed early identification and a more full capture of what was going on for that individual. So the ultimate conclusion here is that both clinician grading and patient reported outcomes are really important. I just want to give a highlight of two studies that I think are good examples to also drive this. So, phase 3 clinical trials are really the hallmark of understanding the impact of an intervention. In this one study, electronic symptom monitoring was used across multiple locations across the United States in over 1,000 patients undergoing cancer treatment. They looked at weekly symptom monitoring by patient report outcomes for things that I mentioned, so like social well-being, cognitive health, physical function, and other outcomes, and showed that the intervention had better, those patients had better physical functioning, better symptom control, and overall better health related quality of life. Because again, they were being monitored, and then as appropriate, interventions can be conducted to help those patients. Another example of a study that was done was one looking at web-based symptom monitoring And this was one that was done in advanced stage lung cancer, where they were trying to understand if the relationship between the symptom monitoring and prompting need for imaging versus routine schedule or interval imaging. And in this study, they found that the symptom monitoring really helped identify early indicators of potential relapse in these patients, and that those patients who were in the web-based had better functional status at relapse because they were undergoing that symptom monitoring. And this group also was shown to have overall enhanced quality of life and improved survival. So we've also done some uh, symptom monitoring here at Wilmot. And here's one example of something focused on cognitive health. This is a study that we did where we looked, and the goal was to see whether or not patients reported a problem. And if they did, if there was referral to services, or if they didn't, we would continue monitoring. And so what we did in this study was we gave questions through my chart, and we also followed up with an objective cognitive assessment. So here, this is just showing you that top is a patient report outcome, showing you that there's a lot of heterogeneity. And so being able to assess symptoms early on allows us to see if somebody has a score that might indicate that they need a potential intervention. And that was one of the outcomes of this study. I just also want to highlight that it's really important and great if we can identify problems, but that we also do a lot of work here to look at different interventions to help with symptoms. So I mentioned some of the work of my colleague, Dr. Mohile, and I know other panelists here are going to be talking about their work as well. Some interventions in physical activity, yoga, led by Drs. Mushton and Lin. I've done some of this work as well as Dr. Lowe and others. Dr. Papone has a whole food based diet intervention. Work by Dr. Aladeen, who helped me with this with some of these slides, is doing really innovative work with VR and meditation. We have a lot of different interventions that and a lot of different work that is being done here in Rochester that's really aimed at helping patients. We take that work and some of the studies done here in Rochester, and we also do that work nationwide as part of our work with the NCI community oncology practice. And this is where we often do a lot of these phase 3 trials. So this is an early introduction to what patient report outcomes are, how they can help. So really in summary, what the evidence shows so far is that patient report of their health can really help with engagement in their healthcare. You can help stay engaged in care, help with clinical discussion and with shared decision making, and can help with identifying interventions that might help you as part of symptom management and then overall survivorship care. So I just want to talk about some of the resources that I usually discuss, which is part of the survivorship program that is here at Wilmot. That we have a specialized clinic in geriatric oncology. We also have a lot of the interventions that are evidence-based that we are also delivering through integrative oncology at Pluta. And so I just wanted to highlight those resources. I know our panelists are going to be talking about some other resources as well. So we are very interested in how to better integrate patient experience into clinical care here at Wilmot. So I know Christina is going to be putting a brief URL into the chat. We really appreciate your taking 3 to 5 minutes to answer some questions for us about how you think patient report outcomes can help with overall care. Sorry, I need some water. So now I want to turn it over to our panelists. I'm going to ask Dr. Burkhoff to first start and introduce herself and talk about the work that she's leading. Julie?
Thank you, Dr. Janelsens, and to our interpreters who are here to provide their service. So thank you very much. My name is Julie Burkhoff. I am trained as a nurse practitioner, and I've worked in the Cancer Center for the last almost 20 years, and I've been at the university for the last 27 years. I mention this because my role is really unique. I am a nurse, I am a nurse practitioner, and I also have the privilege of being the director of nursing for Wilmot's regional locations. Our regional locations span over 14 practices. We cover 28 counties. Our catchment area is about 3 million people. So, all of you who are on today in our community engagement, my world is community oncology, and community representation. Just to give you a quick background, I am from the Upper Peninsula of Michigan. It's like the middle of nowhere. I'm sure none of you know where it is, but I am very used to growing up and living within areas that are underserved. And so for myself as a director of nursing, um, my passion is about recognizing how age, frailty, and cancer services go together. Um, a couple years ago, I completed my doctorate in nursing practice, and my work was partnering with Dr. Jason Zittel, who you'll meet soon, in how can we screen and talk to our patients when we first meet them about um, how they're feeling when they come in. Can our patients report to us how they're doing on their weight? Has their appetite changed? Has their weight changed? Um, do they feel forgetful? Do they feel sad? How can we recognize this and put an objective review together to recognize that chronologic age, when you're 70 can look very different for people. 80 can look very different for people. So we leave the chronological part, we set that aside, and we look at functionally how people are doing, how they are presenting to us. And so my initiative, and so happy to be here to share with you what we're doing from a nursing practice standpoint, is when it within our regional locations, and this is being done at Wilmot Cancer Center also, but to bring this out to our community practices where we don't have as many resources. We're not as resource rich. We don't have our social workers on site for everybody. We don't have nutrition. Um, and we have the services, but they're remote. So what we identified was when our new patients come to the clinic, our ambulatory techs and our nurses are doing a quick screening with a tool called the G8, Geriatric 8. And this tool is a quick 8 questions. Two of them are built already within our electronic medical record, and the others are asked by our techs. But it's really just asking patients, how are you at this moment? Have you lost weight? Are you taking a lot of medications? Have you been forgetful? Do you feel sad? Can you get up and move and get around okay for you? And then how do you feel when we compare you to somebody who's 50 years old, 70 years old? Do you feel you're just as healthy as that person? And what this quick screening tool does, it is allows nursing to provide our physicians with a quick screen to say, we need to be really careful with this patient and be aware of how to take the best care of them. We may need to bring in nutrition. We may need to bring in social work. In this quick tool, the G8, again, that's what it's called, it takes about 3 minutes by a skilled person, 5 minutes when we're learning. So it's very quick. It doesn't slow up clinic, but it provides us a really nice snapshot with how people are presenting to us. So some of the outcomes our patients are reporting. This is how I feel. This is what I'm doing. Some of them are, what is your BMI? How many medicines are you taking? So it really combines both things so that we can partner and take the best care of our patients. It is a Commission on Cancer goal for our team. This G8 is not something I made up. It is proven in the literature as being a great screening tool. It does not take the place of the larger geriatric assessments that Dr. Zittel may talk about. Those are very comprehensive, complex. They take a long time. It's all of the elite experts are in one clinic. My quick screening is to hear from our patients, how are you feeling right when we meet you on day one? And how can we help you make the best choices and support you while you're going through your cancer journey? So that's where I'm coming from within the for nursing and myself. We have, like I said, 14 practices. We have over 200 nurses. We have who make up those practices. We have ambulatory care techs, about 40 of them, and just really proud to be a part of a community practice that's able to capture what do our patients need and how do we best support you. So thank you. Thanks for having me.
That's great. Thank you, Dr. Prakash. It's just really wonderful to hear about all the great work that you're doing. And again, like the community-centered approach is wonderful. It's great
Yeah,
to have you leading this for
thank you.
Wilmot.
It's taking the research that yourself, Dr. Mohile, Dr. Zittel, it's putting research into practice. And that's what I love the most. So thank you.
Great. Thank you so much. So we're going to move to the next panelist to introduce Dr. Zittel.
Yes,
Welcome.
good afternoon. Thank you for having me, and thank you everybody for being here today. I'll piggyback off a lot of what has been said already. My role as a dual trained geriatrician, as well as an oncologist, has been to really integrate many of these principles that we just heard about in terms of caring for patients, particularly older adult patients with cancer, into practice and being able to provide a comprehensive care of our cancer patients as they go through this journey, all the way from diagnosis through survivorship. I initially took a role at the Wilmot Cancer Center doing general oncology practice in one of our community sites, which is attached to Noyes Hospital in Dansville, New York, so a more rural community practice. But I also had a role in a disease-specific group at the main cancer center in Rochester, and really had an opportunity earlier in my career to understand kind of the differences in terms of practicing in the main cancer center versus out in our community practices. Along with this, I've been engaged ever since my residency and training, which was all done through the University of Rochester here, with our amazing geriatric oncology team of both clinicians and researchers, including many of the people here today, and the Cancer Control Group, which really has, I think, in community engagement, has really improved and created a opportunity to really better engage our community and our rural areas in the research and understanding what are the needs that need to be pushed out into these communities. So it's been an exciting career path for me at this point. I recently transitioned out of the main campus up in Rochester for my clinical practice, and I'm fully now down in Dansville for my clinical practice, with really the goal of expanding our geriatric footprint into the southern tier area of our catchment. And so I've been fortunate through our Wilmot team to be able to now provide more comprehensive geriatric assessments, which, as Dr. Janelson had pointed out in one of her slides, really encompasses many of these areas beyond just the burden of symptoms from the disease and the toxicities of our treatments, but also looking at functional status, cognitive status, emotional and psychological aspects of this journey for many of our patients, and being able to look at this and say, what really is going on as a whole for the patient. And most of this information comes from these patient-reported outcomes. The majority of our comprehensive geriatric assessments are these questions that are being posed to our patients who are coming in the door and are completed by them so that we can gain more information so that we can better take care of the patient in front of us. I think I learned early on that as a provider, caring for cancer patients, it's easy to get wrapped up and consumed in the cancer itself, right? And the treatments we're giving, the toxicities associated with that, and easy sometimes to set aside some of the additional challenges that are going on for our patients. And so for myself and being able to provide and learn through our research as well as experience in clinic, that there is so much more to what's happening for our patients beyond just when they sit in front of me and talk about the cancer aspect of it, has become a big learning point for me, as well as helping to guide how I practice clinically, but also the research that we want to bring and the resources that we want to bring out to our communities throughout our whole catchment area. So it's really been a privilege, and excited to continue this work in collaboration with so many of the people here, including Dr. Burkhoff, Dr. Janelson, and our team that you're going to hear from our panelists who are in it and doing it every day, working with our patients, and Gail and Tara as well.
Great. Thank you, Dr. Ziddle. Great to hear about all of your work and experience also in our region and in Dansville in particular. So next, we're going to hear from Tara Coffey.
Thank you. My role here is the manager of community outreach services. Well, I've been here about 24 years. I've spent about the last 15 in community outreach services. I do not actually provide direct patient care, but I do co-facilitate our quarterly cancer services meeting here at Noyes with Sarah Merritt from the Wilmot Cancer Institute. These meetings are actually a catalyst for professionals and community members to come together for an educational presentation and learn about the available resources that we have down here, such as our free wig program that we have here at Noyes. For those that are having transportation issues, we have mobility management services down here in Livingston County, which might be unique for this area, and support groups like our bosom buddies that we have right here in Dansville. They're breast cancer survivors. So the joy of being part of community outreach is the ability to be involved in so many different initiatives throughout the community. I don't focus solely on cancer, but it gives me the knowledge to be able to make the connections for professionals or community members that might need them wherever I might be. So I do the most of my connections outside of the hospital, which is kind of unique. But that was all that I kind of had for my presentation. I will keep it short and sweet, but thank you for having me today.
Thank you so much. Thank you for all the important work that you do. Care can't happen without you and with everybody. And then our final panelist, Gail Feathers. Welcome.
Thanks so much for inviting me. Tara, you actually are pretty humble. She does oversee our medical alert program as well as automated medication system. So myself and my colleagues in case management do refer to her program. So she's being humble there. My name's Gail Ratney Feathers, and I am the senior social worker at Noyes Hospital. I am also the social worker at our outpatient dialysis center in Geneseo. I've been at Noyes I'm in my 28th year, so I've been doing a lot of work throughout the years on our inpatient units, primarily in discharge planning, but anything that our patients need, including guidance with finances, insurance, you name it. So I wanted to really start out by thanking Julie and Dr. Zittel for really speaking about the assessments they do. It's something that I didn't know about, and hopefully you'll understand it and get a little bit of what we do. I think we put together all those assessments. It really provides a comprehensive package of what our patients overall are functioning. Every single patient who is admitted to Noyes Hospital, it is assessed through our case management office, either by a social worker or an RN. Included in that assessment is a social determinants of health assessment, which includes whether, if there's any issues with housing, food, social supports, insurance, or other finances, so that if there are issues regarding that, we can target interventions towards that and give them referrals. We refer to Tara's programs often, but we also at Noyes have an insurance navigator that we refer to often if there's a patient is underinsured or uninsured. So that is something I want to make sure everybody on the panel and our audience is aware of, that we do those kind of assessments, which in collaboration with Julie's assessments and Dr. Zittel's assessment really can provide a really comprehensive overview of how our patients are really thriving or struggling, whatever the case may be. So I just did want to make sure that you were aware of that. I do want to get into some of the physical symptoms we see here when cancer patients present to an inpatient setting. They sometimes come in with neutropenic fever or intractable pain. Mostly they come in with failure to thrive. And that can be defined as physical weakness, weight loss, as I think you were talking about, Doctor, lack of appetite, dehydration, cognitive decline, or confusion. And so we work on interventions trying to figure out what the causes are from our provider perspective. And what we can do to help our patients get back to a functional status. Sometimes we have patients who come in that are end stage and they are too weak to continue treatment, and our providers then will contact Dr. Zittel to come up and talk with the patients, because they often want to talk with their oncologists personally to hear it from them that they can no longer, right now they can't continue treatment, or they're at a stage where they need end-of-life care. So we're thankful that they're right. Dr. Zittel is right here. His colleagues are right here, attached to Noyes Hospital. So if they are able to come, they can provide that continuity of care that our patients really need from them. Sometimes our patients also come in short of breath. So sometimes we do medication interventions. Maybe they haven't been on oxygen before. We get them oxygen. Whatever they need to be functional, we try to accommodate and put those interventions in place for them. From an emotional symptom perspective, there's actually quite a few. I'm going to start off with emotional shock. And that sometimes comes about because the cancer or disease process is progressing faster than they thought. And so the shock of that, not only from the patient's perspective, but the family's perspective, is something that we see here. Another kind of shock is, and I'm sure that you're seeing it across the system or in any inpatient setting, is sometimes we're finding incidental findings of new cancers. So a patient would come in for a different set of symptoms, never having a diagnosis of the cancer, and a mass is found. Sometimes if it's really relevant to what is going on functionally, they'll try to do biopsies here. Sometimes it's deferred and connection to oncology services for follow-up. But those kind of shocks, emotional shocks, we see here. Particularly when you're dealing with the pancreatic mass, as we all know, if they're diagnosed, if they're found in a late stage, which many pancreatic cancers are, prognosis is very short. And so just dealing with that emotional jolt to the system, both for patients and their family members, is something that we do here. We also see denial. And when we're talking about rapid progression of the disease, or just that failure to thrive, we are always hopeful and optimistic that we can get our patients back up and functioning, but sometimes that's just not in the cards for patients. And when that information is given to them, that denial of that this is end of line treatment, there is no further treatment we can give except for the alleviation of symptoms. It's very, very hard. And it's not only the denial by the patient, but it's also the denial of family members. We've had cases where the patients, they understand that this is coming. They're ready for end of life services, but family is not. And family will convince them, you need to go to a nursing home to get rehab and get stronger, when in fact, the patient is at end stage. Sometimes the patient will acquiesce to family demands and go to rehab, and sometimes they die in rehab. Sometimes patients are stronger, and we always try to tell our family members, if your family member has capacity, they can make the decisions for themselves. You don't have, you can try to influence them, but they have the last say. So it's those kinds of things we work with. It's very, very difficult. Is anybody who works in rural health, I know Dr. Zittel comes from a rural community. I grew up in a community south of Buffalo, about 20 minutes from where he grew up. People are fiercely independent in our neck of the woods. They don't want to give up. They want to stay strong. They want to be in their home. And we do everything that we can to try to make that happen. Sometimes we can't do that, but we really try to work with both patients and family members to come up with a discharge plan that really works for the patient primarily. There are caregiver limitations, so patient may want to be home, but with work requirements, or maybe family is out of state, sometimes that can't happen. So we do what we can. We also have a weapon in our arsenal of tools that I'm very, very thankful that we have. Several years ago, it was 2025 now, about 7, 8, 9 years ago, it became more apparent to me in the cases that we were dealing with, especially cancer, that we really needed to develop a palliative care set of interventions. In an readmission initiative that Noyes went through in 2018, I identified that as an intervention that could potentially reduce some of their readmissions when we had people who were that failure to thrive, who went to rehab and they kept coming back because of their symptoms that they were having. Instead of really having a comprehensive goal of care conversation that could maybe direct them to a more appropriate discharge plan. We formalized a relationship with the Highland Hospital palliative care team. They are exceptional professionals who are compassionate and so knowledgeable in directing goals of care conversation with patients. We do telehealth visits with them for our cancer patients, but also others who are having chronic symptoms with chronic illnesses or end of life. And they have been instrumental in helping patients realize that particularly SNF rehab may not be the appropriate setting for them. Maybe it's more a hospice based discharge plan, whether it be to a comfort care home, home hospice, or sometimes even our inpatient hospice care here at Noyes. As I said, care has been transformed here at Noyes, I think, because of their interventions that they can provide. We are so thankful that we have their services, and it's been so helpful. We've also had cancer patients who've come in with intractable pain, and with the help of the palliative care team at Highland, they have been able to help us tweak medications where we've had a patient who was here probably for 10 days, literally could not walk. And by the time that the interventions were put in place, especially through Highland Hospital's palliative care team recommendations, that patient walked out of our hospital, is now functional and still in treatment. So we do what we can here. We try to bring, as I said, that view of overall, looking at a patient overall, what are their psychosocial needs, and those kind of things for our healthcare team members who are here. That assessment, that social determinants of health assessment, is included in our assessment that is in EPIC. So any one of you can access that assessment through our notes.
Okay.
The other thing that I just wanted to say is that we also have a quality component, I think, to our care here. We have our patient relations person, Christy Cartwright, who attends our morning multidisciplinary huddles. And she is always looking to see if there's any complaints, concerns. We want to get to those as quickly as possible. And sometimes we have those. And especially with if there are patients who have cancer, it's really an important part of our team because our patients then felt heard. They felt that their concerns and questions and complaints were heard and that we are addressing them. So as all of us, Dr. Zittel, Julie, Michelle, Tara, as all of us in the healthcare team, we want to make sure our patients have the best chance for positive outcomes as possible. And so that quality component is an important and vital part of that process.
And that is a great way to wrap up
Yep.
this panel discussion and open it up. I want to make sure that we have enough time to be able to get to all of the questions from everyone that's viewing. So if you do have additional questions, please make sure to put them in the Q&A box. If we're not able to get to them during this presentation, we will send it out to all of our panelists, have our answers compiled, and then send them out to you after this is completed with the recording link to the video. So Let's get started. I know that Dr. Janelsons has been busy answering some questions, typing in some answers, so I want to make sure that everybody really kind of gets some answers to these. So if you did not get a chance to view them, if you didn't see them, we'll try to recap. If we don't get to it, again, I will send it out in our follow-up email. So let's start with our first question. How does the Cancer Service work with local services that may help patients with side effects like hair loss, mental health distress, etc.? I'll open this up to everyone, but let me start with Tara, because I know that you mentioned a lot of your transportation services and the wig services that are offered through Noise.
Yeah, absolutely. So we do have our e-beauty wig program, and that is ran through Ashley Derenbecker. She's here in our human resources department. She used to be within community outreach services, but she secured this program through American Cancer Society, and they supply the wigs for us to be able to give for free to whomever may need them. If anybody's looking for one, they can give her a call. The number is 335-6755. And as far as any transportation issues, if professionals would like to reach out to me, because it is a professional only referral system, but we do have our mobility manager, Sean Ryan, here in Livingston County, and he can help connect people to services if he had, because he has funds and all of that good stuff. So he can help out.
And I just wanted to point out too, as far as our community services, we do whatever we can to keep our services within the community. That is really important to refer into the YMCA, your local YMCA for the Live Strongs, and really be able to utilize what you have and maximize what our communities bring to the table.
And with case management and social work at Noise or any of our system hospitals, we make referrals routinely on a daily basis to home health, hospice services, mental health, substance abuse, treatment centers, anything that we can do to help patients. I make referrals often to elder care attorneys. So we usually get, if there's a question that nobody else can answer, it usually lands in case management, and that's okay because that's what we're here for. There should be on the Noise intranet our community resource list. So anybody that is looking for resources, you can look on their Noise intranet for that list. It includes resources in our surrounding counties as well.
I'll just add, because I've seen a lot of these questions coming across, and thank you for the answers, Julie and Michelle, to most of them. But I will just note that from the clinical side of things, many of these PROs that are coming through to us, whether it be for our initiative with the G8 screening, whether it be in clinic when we do and ask questions as part of our comprehensive assessments. There are questions, obviously, as many of us have experienced through my chart and U of R, that are being put out there. These are reviewed in some way by someone from part of the clinical team. So they aren't just going off into space where no one is seeing them. We promise it's worth completing them because they are being reviewed and action is being taken on these. And many of the actions come directly through the services that you've just heard from, many of these ancillary services. Sometimes it's your clinical team that may be directing which services may be appropriate based on the responses you provided from these questions. So it really is a group effort to be able to kind of move forward with these initiatives and implementation of these aspects to try to help improve the symptoms and the care overall. I do think, and I will just say that as outlined here today, we've seen a significant improvement in the number of resources and initiatives throughout much of our catchment area through the affiliations with the University of Rochester, as well as the Cancer Center's efforts, particularly with community engagement. So I saw the one question that was answered about, our integrative oncology center, and is that open to everybody? And the answer is yes. While it's physically located in Henrietta, there is a tremendous online presence for patients to be able to utilize. as well as we've become much, much better with this platform of Zoom to provide many of the services that can't be provided in person. So I think there's a lot of resources out there now that we didn't have in the past, which we're fortunate now to be able to provide because of these efforts.
And I wanted to share also patient-reported outcomes and how our patients and our families and caregivers, how they're feeling. We are listening. And do you ask one time, two times? It's really fluid because how you feel this week may be different next week. And so all of our touch points, we are listening, we are gathering information, and how the skill lies, how do you ask the question? So forever, we as nurses and physicians have been asking, how do you feel? How's this? How's that? But now we're really putting the focus onto our patient and like, tell me your story. Tell me how you're feeling. And that should be happening each and every time that you have an experience with us. It may look different. We don't have a script. We are not McDonald's. Like we don't look the same way all the time. It will look different everywhere you go, but rest assured, we are listening.
The other thing I'd like to add to that, Julie, is in my experience, and maybe you've seen this too, again, in the rural areas, people are fiercely independent. And so they will minimize their symptoms. And so oftentimes we use the collateral information from family members. A patient may talk about, not really realize or minimize a cognitive decline, where family members will give more evidence of a more significant decline. So we always, if possible, can get collateral information on what is happening because the patients often will minimize what's happening to them because they want to be home.
And I wanted to make a couple of points. One is that the survey that we put out includes a list of common problems that all of us have discussed today. And as we as a entity and health system work to refine measures and standardize PRO assessments, we want to know things that are really important to you. So you can help us in that way as part of that really brief survey. I wanted to just highlight too about something that both Dr. Burkhoff and Gail mentioned, and that it's like, don't be shy. So, you might think it's not a big deal, but it it could be. And so if you have something that's new to you, like please bring it up to your provider, even if it's not like in the assessment or screen that the provider's asking. Like, I know you asked me about these things, but I also noticed this. Like, just bring it up because it might be related to something in that screening assessment, and then it can be reviewed and evaluated as others have been mentioning. And the other thing that I think is really important is that not that don't be shy, but like don't wait. So a lot of the literature shows that if people have early symptoms, that it predicts exacerbation of symptoms and problems and complications with treatment. And so it's important to bring those up early. And that's part of the reason that we're implementing these really brief kind of screening PROs so that we can identify problems and then help influence care.
Oftentimes it's the family members who bring their loved ones into the hospital because the patient themselves don't want to be here. And it's the family members who are call the ambulance because things have gotten so bad, or literally kind of somehow get them in the car and bring them to the ER. But yeah.
Exactly. And caregivers can participate in completion of these types of screening tools too. So that's absolutely an important point. So
I'll add, because I just see this last question about do all oncologists use PRO assessments? I think in some degree, as you go to any of our oncologists throughout Wilmot, there is differences in terms of how much PROs are being asked. There are some standard ones, again, that are part of the system that almost everybody is being asked. Other oncologists will use them more than some. I, I do think, though, as highlighted, while we probably should be doing more of it, in all honesty, again, there is some thought of we also don't want to overburden patients with too many surveys, too many my chart messages, and other aspects where then we lose things as part of it. So it is this balance, and as Dr. Jamison was just pointing out, I think hearing from our patients and our community members about where is the right balance of the number of these that should be coming out, how long can they be before someone says, I'm too long for me to answer, there's no way I'm doing all this, I think is an important piece to look at. And then lastly, I'll just note that I will echo as the oncologist, Dr. Jalison's point of please bring forward these symptoms and things that you're going through as part of your treatments and this whole journey because there's nothing worse than having 2 or 3 weeks between visits and hearing that someone suffered with some type of a symptom or an issue for 3 weeks when we could have helped much earlier on. So we have these prescribed visits, we have these prescribed maybe surveys that come out, but at the same time, we do want to hear from you between visits as well if there are things that need to be addressed or that you feel are important for us to address.
And I will close us, Dr. Janelsens, with oftentimes we wait, especially I see this in the rural community practices. I don't want to bother Dr. Burkhoff. I don't want to bother Dr. Zittel. I'm not going to call. It's 6 p.m. Someone is on call for us 24/7, and it is their job. And so they have carved out time to do this. So please make the call in the time. It's absolutely okay. We are built as 24/7 establishment. So thank you.
That is a great way to wrap us up, Julie. I'm very glad that you had a moment to add that in. So for everyone, thank you very much to our panelists and our experts and all of our community members that joined us today. Special thank you to Quinn and Hope, our interpreters, for making sure that this is accessible for our deaf community. Please be sure to follow or to fill out the survey following this webinar. We also will be including the link to Dr. Janelson's survey asking about your feedback on PROs. We will be including that in the follow-up email that you will receive. The webinar has been recorded, so the email that you receive with those links will also provide the link to the video, and we will also include if there are any last-minute questions that were thrown in, we'll try to include any answers, and I will make sure that the questions that were answered via text are included in that email as well. So thank you again, everyone, for joining us, and we'll see you next time.